today I'll be presenting using the Paris data, like you mentioned, Walter, and this is specifically focused on factors that are associated with patient satisfaction in primary care settings. So to provide you with some background, as discussed today, patient-reported outcomes and experiences are well recognized now for quality monitoring and improvement. So PROMS stands for patient-reported outcome measures, gather information related to health, functioning, and quality of life, whereas PREMS, also known as patient-reported experience measures, focus on patients' experiences while receiving care, which reflect organizational care processes. And this is really a way to address inconsistencies between patients and healthcare providers' assessments of patient needs. And it's also a way to provide data on quality healthcare from the patient's perspectives and can contribute to quality improvement cycles as well as clinical and policy decisions. However, such measurement to date has been quite limited in primary care. So the OECD, the Organization for Economic Cooperation and Development, which was previously discussed, provides international standards for reporting on health system performance. And they identified increased public interest in ensuring that patients receive care that is responsive to their needs. And so accordingly, in 2017, as you heard, it launched the Patient-Reported Indicator Survey, also known as PARIS, to build capacity for PREMS and PROMS in primary care. And in having this data, we recognize that there's a need for research on practice level as well as other provider level factors that influence both outcomes and experiences that contribute specifically to satisfaction with care. So the sample for the study consisted of a convenient sample of patients and their providers who were surveyed across 16 practices within Ontario. The eligibility criteria for the patients included age 45 years or older, who had visited their provider in the past 6 months. And then one representative from each practice was surveyed to collect practice level data. In terms of distributing the survey, patient surveys were sent through a generic link through their practice. So rather than the link being sent out by the research team, this was sent out by the practice as a way to increase buy-in. There were 2 surveys that were disseminated. First, a practice survey that was disseminated to providers, and then a patient survey that was disseminated to their patients. So the practice survey consisted of 34 questions about practice characteristics, such as location, practice type, funding models, team compositions, and services that are provided. And then the patient survey consisted of far more, 121 items that covered 4 domains. This included health status and symptoms, managing health, experiences of primary healthcare and services, and lastly, experiences of other healthcare services, as well as sociodemographic characteristics. And embedded within these domains were PREMS and PROMS. So PREMS included questions that were focused on access, comprehensiveness of care, quality of care, person-centeredness, continuity of care, self-management support, safety, and trust. Whereas PREMS had questions pertaining to symptoms, functioning, self-reported health status, mental health, pain, sleep disturbance, fatigue, physical functioning, satisfaction in social roles, and self-management capacity. For data analysis, descriptive statistics were used to describe patients' characteristics, as well as the types of practices that they were a part of. And patient satisfaction was assessed with the question that asked, when taking all things into consideration in relation to the care that you have received, overall, how do you rate the medical care that you've received in the past 12 months from your primary care clinic? And then exposures included patient level and practice level characteristics that are shown here on the box on the left-hand side. Univariate ordinal logistic regression models were run to determine patient level and practice level characteristics that were significantly associated with patient satisfaction. And then all significant variables from the univariate analysis were modeled using a random effects multivariate ordinal logistic regression. In terms of demographics, patient demographics, our results showed that the majority of these participants were aged 55 to 64. Most had completed a community college or post-secondary program. The majority identified as women as well as white, and the sample was distributed quite evenly among income groups. In terms of the provider demographics, among the 16 practices who participated in the survey, the majority were physicians and family medicine, Most were practicing in an intermediate density area and had a group practice with their own patients. This slide here shows the results of variables that were significant in the random effects model, as shown in the red font. So specifically, patients who preferred not to reveal their income had significantly lower satisfaction scores compared to those who had an income of up to $60,000 annually. Patients who are always or usually stressed or worried about having enough money to pay their rent or mortgage had significantly lower satisfaction scores than those who are never worried. Patients who rated their health as very good or excellent had significantly higher satisfaction compared to those who rated their health as good. And patients who had appointments that took place between a few days or up to a week, on the next day and on the same day after initially booking the appointment, had higher satisfaction scores than those whose appointments took place more than 1 month later. And then lastly, patients who went to a clinic where the head of the practice was a nurse practitioner had significantly higher satisfaction scores than those who saw a physician. So the results show us here that financial instability is significantly associated with low patient satisfaction. And this really validates the consideration of materially deprived patients as a priority population. There's a growing literature on potential primary care interventions to address poverty as a social determinant of health. And these include screening tools to assess social needs, welfare rights services such as social prescribing, food insecurity interventions, and promoting healthcare's involvement in affordable housing. However, unfortunately, the potential of these interventions is limited as primary care lacks strong linkages with social services, and navigating these systems can be complex. So this is certainly an area for future research. Wait times for appointments were also seen to influence patient satisfaction, with shorter wait times resulting in higher satisfaction. So it's been well established that accessibility and availability are important characteristics of efficient and effective primary healthcare systems. And longer wait times for primary care appointments are associated with poorer outcomes, and individuals often have no choice but to rely on urgent care. There are a number of strategies that are being implemented to address this problem. This includes having incentives for family physicians to provide additional services on evenings and weekends, and improving other structural interventions such as open access or advanced scheduling, which is focused on reducing and eliminating delays without adding staffing resources by keeping a majority of short appointment slots unscheduled and only filling them on the same day that patients call in for appointments. Also, paying attention to the use of teams in primary care practices that include nurse practitioners and allied health workers. And finally, capitalizing on the use of electronic communication and telephone follow-ups to reduce unnecessary and time-consuming face-to-face appointments while maintaining continuity of care. Finally, patients who were seen by a nurse practitioner had significantly higher satisfaction scores than those who saw a physician. And this is also mirrored in the literature. One study that was conducted with patients who were referred to nurse practitioners in the Netherlands found that satisfaction scores were slightly higher for nurse practitioners in comparison to general practitioners. And the preferred score for nurse practitioners were found for items relating to length of consultation, reassurance about symptoms, information on coping with disease, and attention to the impact of disease on daily life. And in Canada specifically, nurse practitioners have been integrated into primary care to address the doctor shortage problem and to improve patient access to care, as well as lower costs. And across the globe too, nurse practitioner work has been integrated into primary care settings. And this has resulted in individual, community, and societal benefits for vulnerable populations, as well as cost savings and increased access to care. So in conclusion, the findings of this study shed light on several factors that enhance patient satisfaction, including income, self-assessed health status, wait times for appointments, and professional background of the provider. And insights into the factors that are underlying patient satisfaction can help health policymakers and providers to design services and allocate resources to really improve the patient experience. So structuring primary care in ways that address the social determinants of health, drawing on skills and leadership of multidisciplinary teams, and creating efficient systems for reducing wait times and attending to patient perceptions of their health and ability to function in their daily lives are actions that may enhance patient satisfaction.